snippet of what work has been done. There's still more work yet to be done. But let me, we've done some other stuff as well. We've had a couple of deep dives, one within geriatrics extended care, one within the medicine and specialty, across both campuses of what structure and how do we support those as well. And so some changes will probably be coming with that. We're also planning to consolidate the preparation of food to our veterans to one site and transport it. And so these are some changes that are transformational. And how do we work our way through this? So I think a question that may be in some of your minds is how? How are we going to modernize with what we've talked about and within resources that we have? Or how do we come up with those 6 areas to focus on? We had a strategic retreat early part of this year where input from a good 50 of us that were there, our unions, our service line managers, we had other input provided to us as well. But recently, and I feel good about this, is recently a lot have been discussion about foundational services within the VA. What should our foundational services be? How do we put the resources there to meet those foundational services? One is that comprehensive primary care. How do we make sure that we are providing that across the board? That's just not primary care only, but it includes mental health too, the telehealth piece of it, but comprehensive primary care. It's a whole health, looking at community, social services, mental health, as I said. The second one is military-related mental health, PTSD, depression, prevention of suicide, foundational service. And the third one is recovery model of rehabilitation and pain management. Alternative medicine, prosthetics, TBI and SCI, pain management, and substance abuse treatment. That's that modernization which is occurring. We talked about doing today's work today, access. We know a few years ago, when I'll go back to that word that maybe everyone doesn't like to hear, but Phoenix, right? When this began, a lot of this is how do we make sure we get our patients in here, those who want to be seen, seen. We've got to do that. That's why that access is so important. That we look across what we're doing, that we're capturing that we're our workload that we're doing is at the highest productivity that we can be at. And then that goes towards our budget, capturing all that workload so we can say, yes, we're doing everything we are doing, we're capturing it. See, we need more money, more resources to help support that. And that's an important piece as we do it. As we look at our emergency departments, our numbers have steadily increased. We got to look at that. They've steadily increased over year to year. What does that mean? And we have 2 new projects, a project here and a project in Topeka to be able to expand the size of our EDs and be more private. So how do we make sure as we do that change, that we maybe change the throughput, change that flow through there because of a larger and new ED area with an MRI here. We're going to be looking at that. With surgery, we do know that we have decreased our surgery, general surgeon, anesthesia support over the past year. Okay, what should we look like? We look at these foundational services. What do we look like today or in a year or 2 years? Based upon choice comes along with that. Now our veterans have choice. They don't have to travel as far. How does that make up the mix where we go with it? And what do we do well and put the resources there to make it, and to do it very well? We talked about community care and then our CBOCs. Our veterans, as we've heard, don't always want to travel that far. So how do we put the services within our CBOCs so that they don't have to travel as far, especially if it's only a 10-minute, 15-minute appointment? Let's be able to put the resources there as we need to. So, your input. This will be sent out to you, which will give you an opportunity to give feedback to modernization across the VA, Eastern Kansas directly, and this will eventually get back to me. They haven't told me how yet, but it's going to get back to me somehow, so that I can hear that input from you. What we've heard is 5% of budget that we have. For those who don't work in fiscal or our leadership team, does anyone know what 5% of our budget, and it's general purpose, but 5% of our budget, what that number would be. Anyone want to venture a guess? Thinking out there, I guess no one wants to venture a guess, do I? It's $13 to $15 million. We need to realign those services to the Secretary's priorities, one of which is modernization. So how are we going to shift some of those resources to these priorities? We're looking at ways to be able to do that. Probably some tough decisions coming up. But as we get back down to those foundational services of what we should be doing, we're going to put the necessary resources there to meet and achieve those foundational services. There's lots of choices out there. Choices for you and me as employees, and also choices for our veterans. As we also know, healthcare, a lot of chaos going on, turbulence within healthcare. So how do we create that VA system today? Because things have changed 10 years ago. Things have changed from a year ago of how we do care within the VA and in with healthcare. So how do we create it so our veterans choose VA, so that you continue to choose VA? I want your input with that. Yes, Sam?
I have a question. It sounds like years ago we got classified as a 1C facility. And listening to what was presented today, in surgery we're 2 or 3, ED with only some 2 patients a night, is well under a 1C facility. And I know that inpatient medicine with all the specialty medicine are basically one-person departments, pulmonology, cardiology, neurology, etc. That has to be well below a 1C. So my question is, what would the advantages and disadvantages of being reclassified more accurately be?
We haven't really looked into that, Dr. Van Landingham. We know that as I've looked at different data points, every 3 years, the VA looks at all of the facilities and the data, and then classifies them at that 1A, 1B, 1C, level 2, or level 3. Part of that goes into is complexity of workload, so complexity of cases that you may perform within surgery or other specialty services. Some of that is what type of affiliation and residence education that you provide. Some of that is research that is built in within that. There's a myriad of variables within that then would come out and say you are a level 1C or a 2. At the time, and I wasn't here at the time when that changed, we have, as an institution, are just above that level of a new or the lower end of the 1Cs. And whether that changes, I don't know how different that would be and what type of resources. It doesn't necessarily give resources difference for those levels. It's not driven on that. It's based upon workload. Over the past probably 6-7 years, in unique patients that we've seen or we are seeing, hasn't changed very much. Hundreds. 5 years. So we're not growing. And the budget of the VA is static, meaning besides what the Congress, our board of directors, and the president approves, that's the dollar figure that will go to VAs. And so and it's based upon a vision, a region. If Vision 19, which is based in Denver, includes all of that, Denver, Colorado, Utah, Montana, Oklahoma, if they are able to capture and show they're doing so much more workload than we are, they'll get a little bit bigger piece of that, and we won't because we're not showing it. And so we've got to be able to show it, and if we're able to be able to expand it within the resources, then we can do that. So that's where the resources comes from, not necessarily based upon the one level 2 or level 3, but I think that's a great question that I think we need to look at, and I need to have those discussions with Dr. Patterson is, what do you want us to be doing? And will that change the level that we are? All right. We have a few awards to be able to give, so just give us a few more minutes. I want to thank you for being here today. I'm going to turn the time over to Mike. I think you've got this for some of our eye care values.
I'll be real quick, although we don't want to minimize.